Size is 38 by 13. The size of ACL is 33 by 11. With two bundles also. So sa ACL, anteromedial and posterolateral. Sa PCL, the bundle is anterolateral and posteromedial. No? The stronger of the two is the anterolateral bundle. So ulit, ACL, anteromedial bundle for anterior translation. ACL, posterolateral bundle for pivot shift and rotational control. PCL, anterolateral bundle, is stronger than the posteromedial and the one mainly responsible for the posterior translation restraint. Strength is 2,500 to 3,000. Blood supply again is from the medial geniculate. 2,200 native ACL, 4,000 quadruple hamstring, 3,000 bone patellar tendon bone. PCL, 2,500 to 3,000. Blood supply is from the medial geniculate. ACL, blood supply is middle geniculate. So PCL is the primary restraint to posterior tibial translation. The most common mechanism is direct blow to the knee, no, a dashboard, di ba? Dashboard injury. Non-contact pivoting sa ACL. Sa PCL, non-contact hyperflexion. Non-contact hyperflexion. It prevents hyperflexion and sliding. So, physical exam, varus and valgus, no, kasi secondary restraint ang mga ang cruciate. Posterior sag, posterior drawer. The most sensitive is Lachman for the ACL. The most accurate is posterior drawer for the PCL. Quadriceps active and dial test. So, how do you do it? Varus and valgus. So, of course, kapag valgus, you apply an inward pressure on the lateral thigh and you will take note of either pain or opening compared to the lateral side. You're doing it at 0, you're testing the collaterals and the cruciate. You're doing it at 30, you're isolating the collaterals. So, posterior sag, normally, the tibial plateau is 10 mm anterior to the femoral condyle, kaya nakakapanyo sila Gertis. If that becomes absent or posteriorly directed tibial step off indicates a positive posterior sag. Now, posterior drawer, patient supine with knee bent to 90 degrees. Examiner places thumb to knee joint line and pushes the tibia posteriorly, just like the anterior drawer. You do it at 90 degrees. Quadriceps active, if you have a posteriorly sagged tibia and you try to contract your quads, the step off, no, yung posterior sag ay mawawala. Magkakaroon ulit ng 10 mm anterior si tibia. So yun yung tawag sa yun yung positive quadriceps active, no? Quadriceps active. And you do it again at 90 degree of knee flexion. So dial test, no, just the same. So look at the picture, no, negative at 30, no PLC injury. A positive at 30, but negative at 90, positive PLC. A positive at 30, positive at 90, combined PCL, PLC. Okay? And the purpose of dial, again, is to test for posterolateral knee instability. So, classification, nice to know. I think hindi naman nila itatanong yan. No? Pero just the same, no? 0 to 5, 5 to 10, more than 10. So imaging, knee APL becoming the gold standard, quantifying PCL. So you do a stress test, you ask the patient to kneel, and you do you take the X-ray looking at the sagittal view, no? And you measure the distance of tibial translation, posterior tibial translation. So confirmatory study is of course MRI. So chronic PCL may look positive on the MRI because PCL, compared to ACL, PCL has a limited ability to heal, no? Compared sa ACL na no healing potential. Bakit nga daw walang healing potential yung ACL? Ano nga yung meron sa magkabilang stump? Tatandaan niyo ba yun? Presence of there's the presence of myofibroblast daw in between of the two remnant, no? Kaya nagko-contract, kaya there's no healing potential. As compared sa PCL, chronic PCL, you can see a intact PCL in a chronically injured PCL because of its ability to heal. So what's the definition of chronic ligamentous injury? 3 months. So unlike the ACL, the PCL has the potential to heal. Kaya you have a good outcome after a non-operative management of an isolated PCL. So treatment non-operative for grade 1 and 2, quads rehab. Grade 3, immobilization and extension for 4 weeks. For isolated, we are talking about isolated PCL, no? Pero if multiligamentous, so what's the difference pala between knee dislocation and multiligamentous knee injury? If you have knee dislocation, pag multiligamentous, you have any combination, ACL plus, no? At least 2. You call it multiligamentous. Pero if you have knee dislocation, you must have injury to the cruciates and to the lateral, to the collateral. 2 cruciate plus 1 collateral, that's knee dislocation. So all knee dislocations are multiligamentous knee injury, but not all multiligamentous injury are knee dislocations. So surgical PCL if multiligamentous, or if isolated but with bony avulsion. No? You have the following options. So in passing na lang, di naman nila itatanong yan. So you have the arthroscopic transtibial technique. So yan yung ginagawa natin, no? In the open tibial. So if you have transtibial, easier patient positioning. You have the instrumentation, di ba? Yung flip cutter. So ang important yung matandaan dito, I guess, sa lahat ng PCL, bukod dun sa anatomy ng PCL, I think what you need to remember for examination purposes is yung term na killer turn. No? Kasi siya lang meron yan. So when you say killer turn, when the graft will turn from the tibial tunnel going to the femoral tunnel. Ayun, on the picture on your right. So a common site of re-rupture, no? Killer turn. So you have techniques to avoid that. That can be provided by the jig. So open inlay, so it solves the killer turn, and no difference on the outcome. So that's the reference. I think what you need to remember there is number 1, the blood supply, number 2, the examination, and number 3, yung